Subcommittee of Public Health at 11:05. Councilor Warner, would you lead us in prayer?
Yes, sir. Dear Heavenly Father, we thank you for this day, Lord. We thank you for this time of fellowship, Lord. We ask that you fill our hearts with patience and kindness, Lord, as we do your bidding. In Jesus' name we pray. Amen.
Amen. Okay. Not only have roll call, but we need to establish membership since this is the inaugural Public Health Subcommittee meeting. So, Shelley?
I need everybody to not only enter here, but if you want to become a member. So, Mary Baker Shaw.
Can I ask a question real quick? Will this continue on from now on, or?
I'll defer to Councilor Warner on the establishment of the committee and what the plans are
Yes,
going
it'll run opposite at this time. Like next month will be culture committee during this time period. This is every other month subcommittee.
Okay.
Yep.
Public Health Subcommittee.
Thank you.
Okay.
Mike Dobbins.
Here, yes.
Bill England.
Ian, yes.
Keith Austin.
Here, yes.
Harley Buzzard.
Here, yes.
Joe Bird. Sean Crittenden. Frankie Hargis. Wanda Hatfield. Rex Jordan. Yes. Dick Lay. Mike Shambaugh. Eo Smith.
Here, yes.
Denise Taylor. Here. Yes. Victoria Vasquez.
Ani, yes.
David Walkingstick. Brian Warner.
Ani, yes.
And Mary Baker Shaw.
Ani,
And we'd like to be a member,
I'm sorry.
a member of the committee.
Yes, absolutely.
Okay. We have 10 members.
So we do have a point. Okay, we do welcome our public health individuals are from the Public Health Department, and on my agenda, at least, we have Dr. Gann and Dr. Comerford first, but we're flexible. Is that the order?
Switched.
Switch around? Okay, we'll recognize Lisa Pivick first.
Right. Hopefully, is this even on? Can you hear me all right?
Yeah.
Okay, thank you. First of all, I'd like to welcome you this morning and thank you for having us. It's an honor for us to be able to present to you today some more. And we are very pleased and that we're looking in this direction. I want to congratulate all of you for being forward-thinking. This is the first tribal public health legislative subcommittee in the country. And it's being watched by a lot of other tribes across the nation, even those that don't have health departments, to see about how they can implement public health in their communities. So I want to congratulate you and let you know that we all appreciate, and the Cherokee people appreciate your efforts. I'm going to talk a little bit about public health again. I think that we have to continually go over what public health is, what it means to us at Cherokee Nation. So I'm going to go through some of the things that you've seen before and some that you might not have seen before. Then I'm going to show a short 2-minute digital story by one of our staff, and I'll explain a little bit more about that. And then Dr. Gann and Dr. Comerford are going to talk about some of the demographics. They're going to talk about some of the data, things that are going on here within the Cherokee Nation. So you've seen this slide before, and we've used this in accreditation, but it says we are public health. And I've said before that tribes, across the nation there are public health departments, but tribes are really the original stewards of public health. We took care of the water, we took care of the land, we took care of each other. We took care, when we were sick, we made sure we were healthy, and we did it all together. And so I think tribes embody what public health is, and so we use the phrase, we are public health. We prevent, we promote, and we protect. I've shown you these buckets before. This is how you can look at health from a more of a standpoint, a delivery standpoint. There are 3 buckets. Public health is in the last 2 buckets, where you look at we provide services outside the clinical setting, implement interventions that reach whole populations, whereas healthcare delivery is increasing the use of evidence-based clinical delivery within the walls of a health facility. So it kind of helps you to understand a little bit about the context of our health. The next slide is a little more along the lines of what I really want you to look at. What goes into your health? So when we talk about health every month and every year, and I know that many of your calls are from constituents asking about health services and needing health services. If you look at this, this is pretty well nationally accepted. Healthcare delivery inside the walls of a facility account for about 20% of your health. The other 80% of your health status comes from socioeconomic factors, the physical environment, and health behaviors. So when we're coming, yes?
Can you read us those socioeconomic factors? I'm having trouble seeing it both places.
Sure. It's education, job status, family and social support, income, and community safety.
Okay.
So it's your basic socioeconomic and cultural factors, basically where you live and every day. You can see health behaviors, physical environment, socioeconomic factors. So when people are coming into our facilities, we can impact their health about 20% by the things that we do. So what is tribal public health? We're here to promote, protect, and prevent. You can see in some of the pictures that not only individuals, families, workforce, environmental issues, sanitation, water. We're beyond health care and health programs. We have program services that expand into the walls of the clinic, and we have some that are inside of clinical delivery, but we also expand outside of that into the communities and outside of health services. So to really think about it in this context, education, the education department is public health, and the career services is public health, and certainly community services is public health. All of those programs work in conjunction with public health programs. For tribal public health, it helps us, we exercise our self-determination. We define who we are, we define how we're going to take care of our communities, and from a public health perspective, we define what that means to us in the long term. This is a partnership with healthcare delivery. Our services are meant to make sure that the people that come through the doors of our facilities are coming in healthier for our providers and our people to take care of. And it involves a lot of policy, systems, and environment. So it's not just individual behavior, but it's also what's accessible, what's affordable, what you have in your communities, in your home, where you work, live, and play. Now, there are the 10 essential services, and I put these on here because I also put the accreditation sign. We, again, are the first and actually still the only tribal public health system in the nation that has public health accreditation. And we had to meet all 10 of these standards. We had to show competence in all 10 of these standards to achieve that status. And they're the 10 essential services that are accepted nationally by your state, local, city and county health departments, and the services that they do. One of the things that makes us unique is that a lot of public health departments that are located in the state or in a city county health department, they focus only on they don't have access to other social services. They don't have access to education, and they don't always have as many boots on the ground as we have, if you think about what we do as a tribe. So what does the tribal public health mean for the future of our people? And for me, I've been working with Cherokee Nation and for my people for 28 years. And for me, I feel like that our purpose here is to make sure that we continue on the story of the Cherokee Nation and that we contribute to the next generation and those after that. And I know all of you feel the same way. And I feel like that we do that in public health by making healthier communities, giving people the things they need and working in concert with them to make sure that they have all the things that they need in their communities to live healthy lives. And to help in partnership with them, letting them know what their responsibilities are as well in that. Here's another example of public health if you take a look at it. Our environments cultivate our communities, and our communities nurture our health. So you can see a healthy tree that has low infant mortality, lowered stress, lower substance abuse. You have the services that are needed. You have quality schools, access to healthy foods, access to health care, clean environment, transportation resources, access to rec facilities, health insurance, adequate income, quality housing. Those all contribute to the health of a population. And when those are missing, over in the tree on the left, you can see that the other health problems tend to follow. across the nation. And we're not alone in Cherokee Nation having the issues that we have. Those issues are battled across the country in every city, state, county that I can think of. So currently, how are we doing this? What are we doing at Cherokee Nation of Tribal Public Health? You saw the 10 essential services, and you have that, and those are more general services. But specifically, what are we doing with the resources that we have right now? And what we do a tribal health assessment improvement plan and strategic planning. And all of that takes time and resources to look at where we are and where we need to go in the future. We do lots of community partnerships, coalitions, consortiums, civic organizations, working with civic organizations. We do school health awards to promote healthy schools, diabetes prevention program. We do the WINGS program, which many of you are familiar with, open streets, walking groups, walk to school. We have the rec center. We do lots of farm to table, farmers markets, community gardens. The programs in public health also work in clean air and water. And this is in food inspection. This is a time to stop and say, this is a good example of how public health spans outside of the health division, because we have environmental programs outside of the health division and that work on these as well. Suicide prevention, opioid response, crisis teams, our hepatitis C, tobacco abuse prevention, tobacco policy, safe routes to school. There's school dental programs. There's public health nursing that does immunizations and home visits and much more. We have a comprehensive cancer program that has both a cancer tumor registry, focuses on research, and also focuses on access to our screening programs. We work on public health emergencies, for example, pandemic flu, preparing for the pandemic flu. And we do lots of research and development, and we're working on all of these. These are not to the full capacity now, but these are areas that we're developing and continuing to work on. So our challenges and our opportunities both. We have an enormous amount of resources if we pull those resources together and we look at what we have as collectively. And we look at the strength that we have collectively. We have an enormous amount of knowledge. We have, obviously, as is demonstrated today by the initiation of this committee, we have a lot of leadership support. And some of the things that we need to do is continue to define public health for Cherokee Nation and what that means for us and how do we want to operationalize that, how we want to put that and implement that more into our communities. Inclusion of partners, both internal and external, is both a challenge and an opportunity. Making sure that we include all of the players at the table, and all of you know that everyone has priorities in their community. Our hope is that when we have community coalitions, we don't have a community coalition for each separate topic that's going on in a community, but we have one community coalition that looks at the issues that are going on and looks collectively at how we address those and what the resources are. I think it also involves educating non-tribal partners about who we are. Cherokee Nation Public Health Department is recognized as the first tribal public health department accredited across the nation, and we have most of our peers are all within state health departments or large city county health departments. And so we are continually talking to them about the differences between us. The idea that we have the potential at Cherokee Nation to do something that no one in the United States has done, which is have an entire health system under one umbrella. It would be like your state health department and St. John's merging together, because most state health departments don't provide the kind of comprehensive care, clinical delivery care that we do, and most clinical delivery places do not provide the comprehensive public health. But we have an opportunity to really make a difference in the health of all Oklahomans. And also in educating non-tribal members, it's educating the non-tribal citizens that live in our areas to help them to understand that what we do in public health helps everyone. It contributes to every citizen that lives in that community, not just the tribal citizens, but everyone living there. Public health is good for everyone. So, future direction. And I put that up there. Those are my great-nephews. They were all in my living room, if you can see that. They range from under 2 to 8 years old, all in a row, and all boys. And when I looked at this picture I took of them and all arm in arm, I thought, this is one of the things we work for. This is the future. These are the kids, the family. They'll be doing this hopefully someday. And what do we do? So a few months back, or actually about 8 months back, I think it was, that I presented to you guys about what public health is, and I had this same slide without the picture of what our future directions should be. Public Health Subcommittee, I put that in all caps and underlined because we're actually seeing that coming to fruition today, and I'm very excited about this. We've done that. Institutionalizing public health programs. What I would like to see, my dream for the future, is that when someone looks at someone from Cherokee Nation Public Health or someone from Cherokee Nation in the clinical delivery side, they just say Cherokee Nation Health or Cherokee Nation. That we don't have a separated out public health program and a clinical delivery program, but that we're integrated into one. We're developing tools to assist other tribes to do what we do. We've been working closely in the last couple of weeks with the Chickasaw Nation. They did a site visit working with us and what we're doing. We're helping them become accredited and hopefully be the next tribe to become accredited. And we're looking at strategic planning for tribal health and how we do a plan that incorporates public health and our robust clinical delivery into one plan instead of having the public health plan and the clinical delivery plan. So how do we all get involved in this? Local leadership. I think you're a great demonstration today of what can be done with local leadership. Supporting our health care with community action. Embracing what is good now. Is everything perfect? Absolutely not. Do we have challenges that we face every day? We sure do, but we have an enormous amount of knowledge, resources, and what we have that I know is extremely important is that we have an enormous amount of committed citizens to the cause, committed to Cherokee Nation. People ask me how I could work at somewhere so long, but it's not as though I'm working at a job. It's as we're working at a mission. It's a purpose. And I think that separates us out from a lot of other public health departments is that our purpose is the continuation of our people. And I don't believe that public health is any longer optional. I think we are seeing people with late-stage chronic disease earlier and earlier. We're seeing that impacts not just that person, it impacts their family, it impacts their workplace, it impacts the community. And we will never have enough purchased and referred care dollars to take care of everything that's coming into us every day. We will never have that much money. And even taking away the cost part of it, look at what we're losing as far as people and grandparents and great-grandparents and aunts and uncles and people that are there to teach us how to be Cherokee and how to live the Cherokee way. We're losing those people earlier and earlier. So we are tribal public health. And the last time I did this slide, I put the picture of my mom and her grandkids, great-grandkids, grandkid and great-grandkids up there. And this was her 2 years to the date of that last picture. She's now in a nursing home. But she's sitting there, and if you could see the picture closer, you could see that smile on her face. And when I look at this, this tells me the reasons that we do what we do. These are the people, and understanding that someday I hope to be sitting on that couch with, I don't know if I want 8 of them, but no, just kidding. I hope to be sitting there with my grandkids and great-grandkids. And I hope that one of those grandkids or one of those children is sitting where I'm at saying the same things, saying we want to keep this going. We want to make sure that everyone knows who we are. We're a proud people, we're a healthy people, and we're a strong nation. To end that, I'm going to show you a quick 2-minute. I want to show you something about, where's Shay? I want to show you, hold up. It's 2 minutes long, and it's a way that we communicate our messages sometimes. Shane.
Over the past 3 decades, childhood obesity rates have tripled. As a public health professional, I work to make our schools and communities healthier. Children today will be the first generation. Over the past 3 decades, childhood obesity rates have tripled. As a public health professional, I work to make our schools and communities healthier. Children today will be the first generation with a shorter life expectancy than their parents. There is no one program or magic bullet that will take care of this epidemic alone. Children that become obese are more likely to become obese adults. As a mom, I want my 4-year-old son to be able to have safe places to play, healthy foods to eat, and not be exposed to commercial tobacco. Obesity-related illnesses cost our country $150 billion each year. So, how do we make our communities and families healthy? What is my role? What is your role? We can be the change to reverse this trend if we as a community lead by example. Lead by teaching our children the importance of being physically active. Lead by teaching our children about healthy food choices. Lead by teaching our children about the dangers of commercial tobacco. Our children deserve to grow up in healthy Cherokee communities. Lead by supporting policies that make the healthy choice the easy choice, where we live, learn, work, and play. It takes a healthy community to raise a healthy child. Be the change for your family, for your community, for a healthy nation.
Does our health status look like? And can come to talk to you from not only a provider of public health, but also a healthcare provider as well, and what he sees. So we're going to switch spots.
So thank you again for having us today. I just have 5 slides. And you have worked with Dr. Comerford and I on other projects, so you kind of know what we do. But when I was an OBGYN full-time for Cherokee Nation, I always had a lot of questions. I didn't understand when I'd see another 17-year-old pregnant woman, I think, how many, is this a problem here? You know, and I see another woman who has an obesity-related disease, or she's got cervical cancer. And the message I felt, I don't know if it was actually told to me, was that as a physician, I'm only responsible for the person who walks through the door. That's my only job. Once they walk through the door, then they're my problem, and I need to work with them to make them healthier. And I rejected that idea that Cherokee Nation Health Services is responsible for the community. And I discovered that we had a public health department. This is in 2010, after being here for 8 years. And I found a place where I felt like I could do more than only see women in the clinic. So Dr. Comerford and I are the data people, and we have, our primary job is surveillance, which means we just look at things that are happening. We don't dive deep very often to answer the question why. It's pretty much what? So we look at median household income. which is a predictor of health. We look at mortality rates from different diseases. We look at disease rates. We look at some clinical data. What percent of the women that we care for are getting their breast and cervical cancer screening? And we use those data to tell a story to our leaders that this is where we need to work. Because really, if you don't have the data, then it's just your opinion, and it doesn't carry a lot of weight. Now, our biggest burden is to make sure that the data that we hand out is appropriately used, that we know what the biases are, we know how accurate it is, because most of our data are estimates. So we need to understand scientifically, according to the standards, what's the best data we have, and how do we relate that to people who aren't as familiar with the data as we are. So Lisa showed you this slide about the different factors that affect your health, and we measure most of these. So Dr. Comfort and I have access to high school dropout rate. That affects health for sure. We talked about median household income. The physical environment, that's a little bit more difficult to measure. I can see how many parks are in a community and divide that by the number of people that live there and come up with some kind of measurement. We would like to be able to measure the new sidewalk on 4th Street in Tahlequah. How is that going to affect health? That's a built environment, a very positive impact on our community. It's safer, and it makes it easier for people to get that 10,000 steps a day that will make them healthier. Smoking rates, right? Of course, we're going to measure that. Obesity rates, alcohol consumption, birth rates. How about healthy birth rates, preterm birth rates? All those things we can measure, but we have to be able to interpret those data and see what it means to Cherokee Nation. And it can be hard because the data that we bring to Dr. Grimm, he has a different purpose for it than maybe Mr. Warner does or Lisa does. But when we ask the question, how many MRI machines do we need in our new facility? We don't pull a number out of a hat. We pull out data and we analyze it and see what's appropriate. The biggest challenge is always allocating our limited resources. If we get $500,000 to help decrease our smoking rate in Cherokee Nation, we spread that out too thin, then the programs have a lower impact. So where are the smoking rates the highest within Cherokee Nation? And we're just months away from knowing that. We're finishing our health survey, partnering with the University of Oklahoma. Now we'll be able to say in this county it's this rate with a high degree of certainty compared to this other county. That's not easy. It's a tremendous amount of resources to do that. Gradually, in Dr. Comerford and I's 5-year plan, we'll have the capacity to do most of these things. There are some things we don't need to be able to do internally because we don't do them very often, and that's where our partners with the State Health Department and the University of Oklahoma, Oklahoma State University, they love working with us to help us improve the health of our people. So what are the data points? I'll only show you one graph today, and to me it tells a really powerful story about where we need to work in our people's health. And it's called Years of Potential Life Loss Before the Age of 75. And this is mortality data. It's publicly available from the Oklahoma State Health Department. Anyone can open up the internet, go to OK to share, and click the buttons, and these numbers will come out. It's not healthcare data, it's population data, and it comes from death certificates. So if someone dies from a disease at 65, that would add 10 years to that data point for years of potential life loss. They would die at 85, it doesn't subtract 10, it just adds 0. So it's not a rate, it's just a gross number that shows up. So what I pulled were data for Cherokee Nation, and it's the 14 counties of Cherokee Nation, so it's a little bit beyond our borders. And it's from 1 year, 2015, and this is years of potential life loss before the age of 75 for these 12 conditions. And think about the story. What does this tell us where we should be working? So viral hepatitis, that's hepatitis B and hepatitis C. So in 1 year, 2015, 314 years of potential life loss before the age of 75. It doesn't mean that once you turn 75, you're not useful anymore, but think about those 300 years of someone's life that are gone from our people. All right, the next one is diabetes. 414. One of the tricky things with death certificates is there's a physician sitting at a computer that clicks a box. This is what this person died from. So if someone has diabetes and then they have a stroke that might have been caused by diabetes, it just depends on what box they click. So diabetes is a little bit difficult to measure. Lung disease is a little more difficult. That's emphysema, COPD, things like that. It's not pneumonia. So 445. The other challenge with some of these data is how does the doctor or often the funeral home director decide the race of the person who's passed away? Based on our research, we think they look at the person and then click a box. So what we've done, we haven't done it. CDC with the Indian Health Service and the State Health Department have cross-linked the death certificate data with the Indian Health Service. So if a person is listed as something other than Native American at the state, and we have them as a Native American, then the race has changed. And we have access to that data, and it's publicly available. So this is reclassified racial data, and it's the most accurate numbers we have, and it's huge. So we see anywhere from a 20% to a 50% change in rates if we use the racial reclassification. All right, colon cancer. I think we all know someone who's passed from colon cancer, 490 years of potential life lost. And again, this is 1 year. And you start adding the numbers up, and they get pretty high. Alcoholic liver disease, 646. Stroke, 683. Homicide, 706. So, with more research, we can say that the number of people who die from homicide isn't really that high, but they're young people. So it adds a lot to this data point, years of potential life loss. Lung cancer, 983, so the numbers are going up. Accidental poisoning, now we're over 1,000. And again, this is 1 year, 2015, it's the latest data that we have available. That's mostly drug overdose, accidental poisoning. Suicide, 1,300. Motor vehicle accidents, 1,489. And then heart disease. Right, so what's the story? Now, heart disease includes heart attacks, includes heart failure. And you see that I don't have a single data point for cancer. In my medical opinion and for others, cancer is about 150 different diseases. Lung cancer is not breast cancer, is not colon cancer. There's different screening methods, there's different risk factors, there's different causes, there's different treatments. Heart disease is the same disease process, so I keep those together. It's a powerful message. And so when you'll see soon the new mission for Cherokee Nation Health Services, which includes a statement ensuring that the story of the Cherokee people continues. That's 4,000 years in 1 year of not having a grandfather or grandmother, not having a parent. We have 30-year-old men who are dying from heart attacks. So, as a health system, which includes public health, which includes clinical care, we have to work together. Right now, our breast and cervical cancer early detection program is partnering with the Man Killer Clinic. I can go into our health system and see what women are delinquent for their breast and cervical cancer screening. So the first thing we do is we reach out to them and say, hey, did you know it's time? Then we have to partner with the clinic because we have to have the resources to see them. We can facilitate that appointment. But more importantly, if they don't show up, we can call them back and say, what happened? And find the barriers. A lot of people assume that since our patients don't have to pull out their checkbook when they come to see us, that they have 100% access to care. We all know that's not true. I have patients that donate plasma to have enough gas money to come and see me in the clinic. And that's something we can overcome. But public health will identify those barriers, work with our partners to overcome those barriers. So that's why Dr. Comerford and I enjoy our job so much, because we can provide the information that our policymakers need, that our leaders need, and that our decision makers need to make the right decisions, to make these numbers change. So, getting a new blood pressure medicine that works better than what we have will change these numbers a little bit. But imagine if every time were at a community meeting and you were invited to speak, you said, smoking is the #1 cause of preventable death and disease in Cherokee Nation. Because it's true. And one 18-year-old kid says, I'm not going to do it. How much money does that save our system? And think about Lisa's picture of her mom, right? Now that kid, instead of dying when he's 40, will live to be 80 and will contribute, to who we are as a people. So, and then imagine if we all said that and said, oh, by the way, and wear your seatbelts. Motor vehicle accidents, it's a lot of people. Those are young people. And the list goes on. So as leaders in your community, tremendous opportunity to just simple points. Smoking's bad for you. And everyone knows that, but when you hear your elected leader who you respect and who you're counting on to say that, and you hear it again and again, that 12-year-old, so according to the data that we have already, most kids smoke their first cigarette between 10 and 12. They don't start smoking regularly till they're 18. So what happens at 18? We've got some ideas, but we don't have the data yet. Maybe they graduate from high school, then they get a job, and they're around other people who smoke. Or maybe they don't get a job, and they don't have anything else to do. So that message needs to be early. Think of the public health statement it makes when the headquarters of Cherokee Nation puts up a sign that says tobacco-free facility. That means we don't want you to smoke because we care about you, and we want you to live long, healthy lives. All those things that cost nothing have a huge impact on the people we interact with every day. So that's why Lisa and I and the rest of our crew are so excited about this subcommittee, because now we can sit and we can talk about it, and we can work together to change these numbers. So my elevator speech, when I run into the chief or secretary of state, this is where we need to work. Cigarette smoking, poor nutrition, and lack of physical activity are the three main things that contribute to the numbers you just saw. Behavioral health, there's this cloud there that we have a really hard time measuring. And it's not just Cherokee Nation, it's all over. They're difficult questions to ask. They're difficult measures to quantify, like how depressed are you? That's a lot more difficult than what's your blood pressure. And we're getting a handle on that. Of course, behavioral health affects everything that we do every day. People who live alone in a trailer without electricity aren't really concerned about whether or not they quit smoking. It's just not high on their priority list. They need to get some food. And so these are the things that I think about every day. Cigarette smoking, poor nutrition, lack of physical activity. These are health behaviors that are infected by the environment. And again, you've seen all the slides from Lisa. I think the take-home message for me, when I get lost and things get overwhelming or I get confused, I see Lisa, and Lisa asks me, Dave, why do you do this? To kind of get me refocused. And it's because we're responsible. Cherokee Nation Health Services is not only responsible for the people who walk through the door, we're responsible for the whole community and for the whole Cherokee people and the whole communities who are the guests. When we build a ball field in Bonita, it impacts the whole community regardless of their race. And the work that we do is long lasting. One of the hardest parts about public health is that the outcomes we want to achieve are often very distant. In the hospital, I can say, oh, we did 100 more mammograms this month than before. Check, right? We've improved. For us to see a decrease in childhood obesity rates takes years to realize. So we do a lot of process measures, how many gyms are available. The School Health Leadership Grant has had a huge impact, we think. Right? We can say the number of kids that were affected, but that impact on the health of Cherokee Nation won't be seen for a generation. Thank you very much. Any questions for us? Yes, ma'am.
Yes. On that graph, I noticed that there was not obesity in the charts. Is it because it affects so many of these other things?
Right. So that's like a step down. When our whole vital statistics system in the United States has a list of possible causes that people can die from, and you're restricted to those. So obesity usually causes some medical problem which leads to death, and that's what shows up. So, a heart attack, right? If it's because they're overweight, then that's where it would show up. We can estimate that, but I think when we get to a population the size of Cherokee Nation, the science doesn't hold up very well. So it's one thing to measure the way things are. The more difficult thing is to measure trends. So if I look at this for the next year, and the number for heart disease goes from 4,200 to 4,100, is that a real change, or is that just a random, just so happened that year a few more people didn't pass? So when you look at obesity and those estimates have a lot more bias and uncertainty in them, then that gets difficult. Now, our healthcare data tells us a lot about, we measure the height and weight of everyone who walks through the door, but that's just the people who walk through the door. How many of the people that we're responsible for don't engage our system? Or the only time they do, it's because they have a toothache or they break their arm to go to the emergency room. How does that reflect a community, the number of people who happen to use Cherokee Nation Health Services? So we have to be very careful when we try to use healthcare data to describe our communities.
Your data is coming from Cherokee Nation Health.
No, these data are from the Oklahoma State Department of Health Division of Vital Statistics.
Okay. And it's all 14 counties, including the neighboring jurisdictions that share the same county.
Yes, sir.
Okay. So I was just making sure that we, North Tulsa and Nowata, and that they were actually reflecting in these numbers.
Yes, sir, they are. So it's beyond our jurisdictional borders, and includes the entirety of all 14 counties. I can't yet narrow this vital statistics data to just the jurisdiction.
Well, I think it's kind of telling if you take that and take the top third, that's the accidental poisoning up to heart disease. The bottom 8 actually are almost the same amount as heart disease is combined.
Yes, sir. I think total adds up to about 13,000, and this is just the top 12, right? So there's a whole other list of things that people pass early from. It's in 1 year. So you think about 13,000 years of who the Cherokee people are lost. And that's a powerful story, and it's important. And it can get really depressing, right? But the work, when I hear the kids on the creek where I live laughing and jumping in the water, we can beat this. This is a winnable battle for sure.
I have a question. Do we have the ability to do any epidemiology studies comparing in our 14 counties, say, the prevalence of heart disease at the J Clinic versus the prevalence of heart disease at Three Rivers or Hastings? Have we got to where we discern differences across the 14 counties? We're just looking at all in toto here.
It depends on exactly what we're looking at. The prevalence of heart disease is very different from measuring the mortality from heart disease. So in our healthcare system, I can measure that. How many patients here have a diagnosis of heart disease in one clinic versus the other? I would have to look really closely to see where the uncertainties are. So what if someone goes to both places? I have to make sure they're not represented both. What if when we do healthcare research on diagnoses, those are based on codes that the coders use, and there might be 13 different codes for heart disease, and the coder might have used one versus the other, and the patient falls off the list. So that gets a little tricky. The state doesn't measure well for us the prevalence of certain diseases in the community. There's the Behavioral Risk Factor Surveillance System, which is a nationwide survey, and we're trying to work with the state to oversample Northeast Oklahoma to give us better data on how many fruits and vegetables people eat, how often they exercise, how often they're depressed, a whole host of questions. Our health survey that's currently underway asks some of those questions, but it takes a tremendous amount of money and resources to do that kind of study, and it's something we can't afford to do every year or every 2 years. It's more like an every 5-year project.
I know the University of Tulsa has done some epidemiology studies, I guess, probably using some of this criteria. And they found a difference in life expectancy of about 8 years between different zip codes in Tulsa. 8 years. And I know a lot of it is access to care, and you mentioned socioeconomic conditions affecting that, but I was just wondering if we were to do that within the Cherokee Nation, if we found out a Cherokee citizen in Tahlequah lived longer than one in Muskogee, why is that?
Yeah, we've looked closer at that. We don't quite have the capacity. I'll need to get the raw data from the state health department and work with our GIS department to extract the zip codes from the data and put it on a map to look at those.
One of the most recent funding applications that we submitted required that we take what the census considers vulnerable populations within our census tracts and overlay it with our population and find out where some of the vulnerable areas are. And we have done a little bit of that work. I have seen a lot of the stuff done by zip codes. As a matter of fact, some of the things that Dr. Grimm has shared with me from the Lynn Institute from Oklahoma City, where they did a lot of work with zip codes, that's where we're hoping we can go at some point, is being able to really nail down where, specifically in the reservation that we need to be, or where we need to put the most resources. Because you're right, within the Cherokee Nation, there are disparate areas. There are areas that have more needs than the other areas if we look at it from truly facts and the statistics point. So that's coming hopefully soon.
Data, right?
And I think you're absolutely right, Lisa. Probably the people, and I'm going to use Tahlequah for example, have more physical activity that we have in Kenwood. They have a gym, we don't have a gym. They have sidewalks, we don't have sidewalks. They have a walking, running trail, we don't have that up there. And I've seen a difference since I've been here for several years. I've seen a difference when you started the program here with the walking trail. How that benefited the rural areas most. Probably the most beneficial thing we've done as far as preventing health. And I think what we talked about before is we spend a lot of money on health care, and I think this is an important time to say it, is preventive health care. It's like the doctor said a while ago, you build a sidewalk, people are going to walk on it. Well, we got sidewalks, say in Tulsa, and those sidewalks are used, but if you look at Jay, you look at Kenwood, there's no sidewalks. People walk in the road. Walking trails and running trails are important. I've talked about farm to market stuff here a lot of times in our committee meetings about raising healthy foods and vegetables and put them into our clinics and donated food warehouses and things like that. So we're not spending enough money on preventive health. That's exactly right. We'll talk a little about the data that you talked about. Is this include all natives in our 14 county jurisdiction, not just Cherokee?
Correct.
Okay. Is there any way you could get just Cherokee? I know with some of the organizations, they all lump it in as native, but I think it's important us to see if we can get Cherokee numbers also.
Right. So the vital statistics data do not include tribe membership, and that's again one of those epidemiology questions. If someone has a Cherokee mom and a Choctaw dad, what do they say they are? In the data. Our healthcare data has that, so I can pull the healthcare data, but not the census data or our other health survey data. And with our behavioral risk factor surveillance system, it's self-reported. How many people have a CDIB card who don't identify as Native American? We think it's significant.
And I'm surprised that you can get all that stuff off the U.S. Census data information. We used to use it in the roads program. And you have to have that before you can make a determination on where you're spending your dollars. So data is what you got to go to.
Dr. Comerford recently did a a short survey of women for the breast and cervical early detection program, asking about knowledge and attitudes on breast and cervical cancer screening, and half the women didn't get a mammogram because they were afraid they had cancer. So that's a barrier, right? So how do we, as community leaders, go get your mammogram? It'll be okay. We're there for you. We have the resources. Why are you afraid? And you work with those people.
I want to address your question or your comment just quickly, and yeah, I agree. I mean, there are, I think across the nation, United States, there's a lack of resources in prevention. But one of the things that I want to really hit on is that in working in public health and prevention, I try to be really careful that I don't set it up between dollars between clinical delivery and dollars between prevention, because I don't want to set that up. I don't want it to feel like, because the dollars that we have for clinical delivery are all necessary and needed. We have a lot of people that need our help and care. And what I see in public health is that there are a ton of opportunities for us to leverage resources that we already have if we work together with our, not only within the Cherokee Nation, within programs, but also outside of the Cherokee Nation together. And I see this as a positive step for and leadership from your perspective. Also, a lot of the resources that are out there that we apply for require that you have a proactive stance, which you are taking right now. And when funders see that we have a proactive stance on prevention activities, then we have a better chance of being able to access those resources.
Mary?
Yes, Lisa, you mentioned the Lynn Institute a while ago. Are you all working with the Lynn Institute?
Yeah, we actually have a meeting with them in about a couple of weeks. We're going to sit down and talk to them about the work that they did in Oklahoma City, and then what, how that might look like what it looks like in a rural community versus an urban community such as Oklahoma City, and what's available. So yes, we are going to sit down and talk with them soon.
I'm delighted to hear that because they're so renowned. Next question. Strategic planning. What is the status of our strategic plan in public health?
The strategic plan for health services, we're doing one combined strategic plan for all of health services together, and we just had an initial planning just with the health administration staff. We sat down and looked at some ideas, and we are waiting for a document that's going to come back that we're going to vet through all of the stakeholders to see what types, if the strategic planning meets the needs for everyone. And we're working with, actually it's funded through the Centers for Disease Control and Prevention is funding our strategic planning efforts, so we aren't taking any dollars away from any healthcare resources or services, but because the Cherokee Nation is so proactive, federal agencies like Centers for Disease Control help give us planning dollars. So
I'm so glad to hear that. Thank you.
Mm-hmm.
Any other questions? Thank you. Lisa, Dr. Gann, Dr. Comfort, Julie, thank you very much for coming.
thank you.
Yeah, thank you very much.
No old business, no new
I
business.
just got one
Okay.
comment. I just want to say thank you guys for coming, and to me, this slide right here really hits home, other than, the graph with the statistical data with the years lost is also another one, but when you look at this breakdown, we need, when we're thinking about treating ourselves, we think about treating the whole body. So when you look at healthcare, I hope that we start thinking about, like Lisa and Dr. Gann said, that healthcare is one, it's not separate from the clinical side, from the public side, but when you start to look at this, and that 20% down at the bottom is our healthcare, and we do a great job at that, and we put a lot of emphasis on that. We just don't need to forget about the other 80% and some of the things that we already do. We're not knocking ourselves now, but you look at what we do in education, you look at what we do for jobs, you look at what we do for community support, community safety. We're already tying some of this in. I think it's just time to start recognizing what we have been doing, and also can we augment these things in a healthy way to help generations down the road, like Chief Baker's always talking 7 generations to come. If we don't take that active step now, where are we going to be in 7 generations? So, and I think, and it's just, they've already, the light into the path is there. Now, it's time for us to help pick up the baton as the leadership and people are already recognizing what we do. And thank you guys for what you've already done. Appreciate you. Thank you, Doctor.
Thank you, Brian, and I commend Brian for actually helping make this happen, this proactive first step, as the way Lisa described being proactive. Any other comments, questions? Old business? Don't have any old business, this being the first meeting. New business? Any announcements? I would entertain a motion to adjourn. Second? Meeting adjourned.